Thank you everyone for coming. Usually say good morning or good afternoon. It's good midday. I want to welcome everyone to the second, not annual, but biennial, I guess, Stanford Medicine Children's Health Research Community event. We held the last event in June. It was the same setting very much, but a much different agenda. My name is Karl Sylvester. I'm a professor of surgery and pediatrics. I operate and take care of little babies, work with many of you in that effort. On the academic side, I'm the Associate Dean for Maternal Child Health Research, which means I have a role in bridging the School of Medicine, infrastructure, compliance, regulation into the hospital. And so I work with leaders across both the school and the hospital, and we've got several of those leaders present today. But today is different. Today, we're going to talk about why are we here? And why we're here is because of translational research and innovation. And so what does that mean? I'm sure you can all come up with your own definition, but I think sometimes just having a conversation about what that is and why we're here would be informative as to what we're going to talk about later today and is demonstrated by our cast of speakers. To me, translational research starts and ends with the patient. All of our research efforts typically start with an observation, a question, an unsolved need, an unmet need that we see in our patients that need to be addressed. Many times it becomes an observation that goes back to a laboratory, it goes to a computer, maybe it's in a radiology suite, and then it comes back to the patient's bedside. And that's that last part of coming back to the patient and imparting that as either a device, a service, a drug, a new program, a new operation, a new way of imaging a patient is what we think about when we think about innovation. And it's innovative when it's adopted and it impacts a life in a meaningful way that people value. And by that, we mean that the patient themselves value, and that voice is so important. And in today's agenda, we're going to hear from a patient family who has benefited from one of those translational research projects and the innovations that have actually occurred, grew up here, is now embodied here. In addition to that, we're going to hear from some speakers this morning about their work, Justin Baker specifically, and he's going to talk to us about his program, which very much fits and is an embodiment of that very same paradigm. It's important to recognize that this is a partnership with the School of Medicine, but at the same time, it has to be very customized. We spent many, many years and a lot of time thinking about this to a women's and children's hospital. And fundamentally, Maternal Child Health Research Institute is the core to building and bridging those processes. In our office that I direct with Mary Chen, the Clinical Research Support Office, that's what we view our job as, is how do we take all these fantastic things and break down barriers so that these observations and these innovations and this translational research can make it back to the bedside. And that's where each of you comes in, right? So whether you are a technician, you're a faculty member, you're a clerk, you're a hospital administrator, we strongly believe that we all have a role to play in that. And that's why you're here. That's why we do what we do. Part of our mission statement is translational research and breakthrough discoveries. And so how do we bring that into life? In our office at an MCHRI, we spend a lot of time with hospital administration thinking about the answer to this question. And this is really where we started, literally 5 years ago. And this question remains true today. And that is, how do you execute patient research within a healthcare system designed primarily for clinical care? There's no question that we have excellence in clinical care. We're a quaternary referral center and all the extraordinary things that we do here today. What makes us extraordinary and which will carry us into the future as being extraordinary is the translational research and innovation that each of you is involved with on a regular basis. And if you're not involved, we would welcome you into the conversation and talk to your leaders. Maybe you'll see something today or be sparked an idea or spark up a conversation with those sitting next to you. And that's what today is about. So we're going to hear from faculty members. We're going to hear from, most importantly, a family about their perspective, which is really what this is all about. And then it's about you and how can you be involved and how do you see yourself in this conversation? And that's really what we welcome. Okay, so having said that, let me bring up Mary Leonard, who's going to make a few introductory comments. Mary doesn't need any introduction. She, of course, is the professor and chair of pediatrics at the School of Medicine. She also directs Maternal Child Health Research Institute, and she's the physician-in-chief at Stanford Medicine Children's Health. Mary, come on up.
Thank you, Carl. So as I was listening to Carl for a minute, I thought maybe I should just throw away my remarks and take a different tack. Carl, when you were talking about the children you take care of. So for 17 years before I came into this role, I ran a clinical research program in children with renal failure at the Children's Hospital of Philadelphia. And I enrolled hundreds of kids in my research studies, including 138 kids that were enrolled in a randomized clinical trial. When I think about the work that I did, those children, we were asking their parents that this study involved exposure to radiation. It was a huge amount of work. I could never have done it if the dialysis nurses and the renal nutritionists and the people that were at the side of those children day in and day out didn't understand what we were doing and believe in what. And they were incredibly important partners because the patients would turn to them and go, do you think I should do this? So we absolutely positively cannot do this without the entire community. And we're just so grateful to have everybody here together. These are, I think, really special events. I'll just say a little bit of background about MCHRI for people who aren't as familiar with it. It is one of 5 institutes in the School of Medicine. It was founded in 2010. We have just been very intentional in our work to spread the maternal and child health agenda across this entire campus. So we now have 1,300 members, and our membership not only represents all the clinical departments and the basic science departments in the School of Medicine, but we have members across the entire campus. So the School of Education, Engineering, Psychology, it's really wonderful, very transdisciplinary program. We have 3 pillars of things that we do. The first and foremost is we had a lot of grants. So we gave out $11 million in grants last year. Some of them are specific for specific areas based on a donor intent. Others are just based on some very wonderful endowments that were created at the inception of the Institute. We gave out 168 grants, and over 107 faculty have served as reviewers on our study section. So this is a huge commitment to maternal and child health. For today's purposes, I think much of what we've built over the last 5 years, and we have an incredible debt of gratitude to Karl for his visionary leadership and to Allison Falwell especially, is this clinical research support office. In all my years at the Children's Hospital of Philadelphia, where I was director of clinical and translational research, we never broke through and made that kind of a connection with the hospital leadership and the folks throughout the entire hospital. And it really has been transformative what this group has accomplished. So really grateful, Rick, to you for serving on the exec, and Natalie and Jesus, and the whole hospital C-suite has been deeply invested in this work and it's really made it possible. We had hundreds of people here in June, and we're going to keep doing this. We think these events are really important. I just want to say a little bit about the clinical research support informatics team. CJO really has done incredible work specifically through informatics, people who need custom Epic order sets, that sort of thing. So last year alone, they fielded over 500 research requests. And then the clinical research coordinators, this incredible team of really expert, experienced clinical research coordinators that Mary Chen built, has supported over 200 studies last year. The third pillar in MCHRI is education. So we hope you're aware of our monthly education, the whole series, the monthly seminar series, and then our annual symposium. Be on the lookout for that every year. It's in the fall. And each year we pick a really hard, thorny issue. So this year it was all around disinformation, and artificial intelligence, and how we can use artificial intelligence and build trust was part of that. Last year it was on climate. So we tackle the hard problems. And so really grateful to all the people that have contributed to that. I'm really excited about today's agenda. We have a family, we have incredible researchers, but what I hope every single one of you leaves with is an incredible sense of pride. I don't know of any other children's hospital in this country that has this level of engagement between the faculty, the scientists, and the hospital leaders, the managers, all the way up to the C-suite. We should be incredibly proud of the work that's being done here. I want to give thanks to many people. Allison, I know we're going to hear from, but Mary Chen, Netta Miller, Harmon, Kevin, Allison Falwell. This is really an extraordinary team, and I'm really looking forward to today's event. Remind me who's next. Do you back up? Okay, thanks.
Cool. Thanks so much, Mary, as always. And Mary truly is obviously the visionary leader of all things translational research at Children's. Just a quick anecdote to keep this personal. When Mary first arrived, and Mary was in her initial role, she was the Associate Dean of Maternal Child Health Research under David Stevenson. And as she became chair, I took her job. So I don't want her current job, but I love working with Mary. She's a fantastic human being, and she's a wonderful leader from so many different perspectives. So thanks, Mary. So keeping with the spirit, again, this is a partnership. It is definitely school. It is definitely hospital. And we have a partner in Rick Majzun, who is the COO of the Children's Hospital and the Senior Vice President, Executive Vice President at the Children's Hospital. Rick has been an amazing partner. We've intensified this conversation over the last year or two, and Rick is definitely on board. He gets it, and he's been so supportive and definitely recognizes the role that the Children's Hospital themselves, both in administration and, again, each of you, whether you're an employee for the school or the hospital, we all are in this together, and Rick really embodies that and supports it so much. So we're going to bring up Rick to just say a few comments. Rick, thanks.
Thank you, Karl. It is very true. I think this is all of our work. And in preparation for this, what I did is I actually talked to a number of our leaders throughout the organization, and you'll see they're from a variety of different places. Because I say all the time, this is all of our work. We all work in research. We all get to contribute to this. But I kind of wanted to test it and see what people came back and said. So Rishi Seth, the vice president who oversees so many different areas for him, called it a fundamental part of his job. And he talked about the fact that it's really, really important to him personally that we're taking research from the bench to the bedside, and that we're making sure that we've got space in the hospital for people to do that work, right? As Mary and Karl both said, the reason that we do this is to help take care of great patients, right? And we want to make sure that we're bringing stuff out of the lab into the hospital rooms, into the clinic rooms. Jill Sullivan, who leads our general services team and our facilities team, said that, you know, my team participates in research projects as needed, making sure they've got the right space and facilities. She has to say no a lot for those of you who had to try and find space in the hospital, and she feels very guilty about it because Jill's a nurse by training and recognizes her team's important role in this. And then also brought up the fact that she really drives her team to make sure they're bringing research forward to spread with the industry, and they present quite a bit nationally on things like sustainability and energy management and building design and engineering. Colin James, who's a manager in an REI clinic, talked about how his team uses research as a foundation of treatment decisions, and importantly, how they use it to develop systems that help create more equitable outcomes. And his phrase is learn, share, spread, repeat, which I really think is sort of a great new Stanfordism. Annette Nasser, who leads our Department of Nursing Research and Evidence-Based Practice, brought up the Interprofessional Clinicians Program, ICP. And this is a partnership between her department and MCHRI to give clinicians who are not faculty protected time and resources to do some really, really cool work. You all might remember the last time in June when we talked about this, we talked about a little project that was on balance in the vestibular system and eye movement for kids who had concussions. My daughter was one of them and benefited from that study, and the impact of IUDs on endometrial lining. My 17-year-old daughter has not benefited from that one yet, but maybe will one day soon. And by the way, the deadline for those proposals is 1/13/2025. They're taking proposals right now. So for those of you who have interest in furthering your personal work, as Mary said, in research, this is a great opportunity for our hospital folks. Sean Tankin, who leads our revenue cycle function, right? You wouldn't think revenue cycle that they would view their role as taking stress away from our patients. And when he started his email with that, I thought, what is he talking about? And what he said is, for many patients, the promise of clinical breakthroughs and cutting-edge therapies is mirrored by an immense anxiety about cost, coverage, and potential medical debt. Since Stanford frequently leads and/or participates in clinical trials, my team spends significant time helping both researchers and patients understand which components of care are covered by insurance, ensures that patients aren't billed inappropriately for those services. So even if your job is to take care of the money coming into the system from our clinical care, here you view your job as research. The other point that he added is that also it's wonderful because it makes it such that families don't get scared away from doing research, right? There are a lot of barriers to getting families into research. Once we can get them into our studies and our protocols, we can do great work for them, and having those financial aspects of them covered is great. Just three more. Zach Seow, who leads our radiology team, he helped to develop their intake system. I think Allison has called them sort of the poster child, the best practice for how you get research into a clinical department. They've got an intake committee made up of their providers, their clinical and administrative staff, who go over all the research projects and make sure that they're getting those integrated into their practice, and then actually using that research to make sure that they can give better images, give better patient care, and importantly, train and develop elite level talent. Jessie Bargman-Loach leads our CPMV team and talks about how her team really supports the research mission all throughout the quality improvement functions that she does, and then really actually then helps to take that out and spread this through national organizations. And finally, Allison Falwell, who, if you know her, you love her. She's absolutely amazing. And I think, as Mary said, the CRSO has been a wonderful, wonderful bridge between the hospital and the medical school. And Allison is the person like holding those edges of that bridge together. And she brought up a couple projects that are really cool. A TPN project right now that is looking at artificial intelligence and figuring out how can we deliver the right nutritional support to some of our premature babies. The Epic Genomics module, so that we can not only get better information to our families now for their care planning immediately and their future care, but also tap into all the resources across the EPIC genomics database. And then finally, the baby bonus study, which is a wonderful study, a guaranteed basic income study that we're doing in conjunction with the School of Education to really look at if you give parents to be a guaranteed basic income in San Mateo County, it's about 1,200 families, what impact can you make on them? So wonderful, wonderful way that research is actually making equity, a primary goal for the organization. So I think these are wonderful examples. I didn't have to write any of them. These are real life examples from people across our organization, and really proud of all the work that we're all getting to do together on this. So, Carl?
That was awesome. Thank you so much. I learned some things I didn't know, which was really, really cool, and it's really gratifying actually, again, to see how much this message has grown and how much people are really engaged because of your leadership, but also because of the conversation. So it's so nice to hear of people really coming forward with some of these examples. It was really great to hear. So thank you for that. Okay, let's get to the heart of the matter here. Our speakers, right? And so our first speaker, I'm going to just read some titles and then I'm going to say a few things about Justin. Justin Baker is a professor of pediatrics. He's the chief of the division of quality of life and pediatric palliative care. He also directs quality of life for all program, also known as Koala. I am the happy recipient of the Koala this morning from Justin. It's the first time we've met in person, although we've met on Zoom many times. He's also the associate chief quality officer for patient experience and holistic care. Dr. Baker's research interests include ethical considerations surrounding enrollment in clinical trials, palliative oncology care, end-of-life decision-making, grief, bereavement, intelligent palliative care, into the ongoing care of children with cancer, as well as patient-reported outcomes and pain control in the context of pediatric oncology care. If that's not enough, Justin is just really a terrific guy. When we were inviting him to come to this symposium and speak, all I had to do was get on Zoom and have a conversation with him. And I was like, this guy's gonna nail it. He's a perfect speaker. He's been invariably described as colorful, lights up a room, timely, and you'll see why in a moment when he comes up and begins with his remarks. So Justin, come on up, and I look forward to hearing from you.
Thank you so much, Carl, and it is great to be here with you all. I didn't know we were going to hear lights up a room, but I mean, come on, that feels like on brand. So the other part I need to start with, and I'm sorry for this, is we need to start with a selfie. That's how all good talks should start. So here, I'm up here so I can catch it. I'm going to catch it over here by my mic. Look at that. You all are too many. Okay. That was for posterity. Oh my gosh. Y'all look, Mike, you don't look very good, but the rest, everybody looks all right. It's hard when you're in a 0.5 selfie. I'm an Instagram dad. I have 4 kids, 3 daughters, and an amazing son. And the closest person to the 0.5 selfie gets a little distorted. So sorry about that. So up here, it says the word palliative. I need some people to yell out some thoughts on what does that mean? What does palliative mean to you? Comfort care. Carl gets a koala. Oh, come on there. Very good. Oh, I missed. That was a little wide. That was a good throw. Somebody way over there. That was compassion. Support. Great. That's good. See, let's see if I can get it to you. Ready? Everyone around her, watch. Oh, did you guys see that? That was awesome. That's one of the furthest I've connected on. So when you think about palliative care, and when you think about it in the context of research, which I'm going to talk a little bit more about, the word palliare means to cloak or to cover. And I love to think about that term when we think about palliative care, because it's this extra layer of support as a subspecialty team. And then what it is it's this compassionate ability to connect with our patients and families. So you brought up compassion. The word literally means to suffer with. Kom pati, kom with pati, to suffer with our patients and families. And when I think about this, I think of palliative care as kind of this anti-suffering field. And what we're really about, I'm also an oncologist. And so as an oncologist, the disease I treat is cancer. As a palliative care doctor, the disease I treat, the studies I do are around suffering. And we obviously have a koala that we have as a part of things, because we really like to try to take a lot of people, when you say palliative, and I'm sure a lot of you are thinking this and didn't say it out loud. Thank you for all the people that said what they said, because that was wonderful. Many people think it's about end-of-life care exclusively, or about hospice or things like this. So we came up with this koala to talk about quality of life for all, because that's really what it's all about. And if I didn't call us the Quality of Life for All team, the koala team, I would have called us the Get Her Done team, because I love talking to patients and families and saying things like, what would make today better for you? How can you think about that? And if there's something you think about, call us and we'll try to get her done. So that is why I wish we had been called that as well. But maybe we'll call her the Get Her Done koala team, maybe both. The cool part, and I'm going to talk a little bit about some of the research that we've done. We're getting further and further and more advanced in our studies to be able to show that we do improve when subspecialty palliative care is involved. Quality of life gets better, psychosocial outcomes improve, caregiver burden decreases, and we can reduce overall cost to a system. And so I think these are great things. When you think about the research, you also have to think about what's that disease that we are treating. And so when you think of that disease of suffering, who knows what picture this is? Look, I'm reaching down for a koala. Scream, okay, I had a hand. Oh man, I went wide. I'm sorry, that just drifted on me. And so, do you know who Munch's muse was? Does anybody know? Yeah, that's right. Okay, I'm not that old, but yes, I got to go visit this and do a talk there in Oslo, and that was amazing. The museum, I really would encourage you to go there. But when you think about suffering, there are these concepts of total pain, total suffering. You have to really think about physical symptoms, psychosocial issues, and all of these things in the context of our precious patients and their families. And these are the things that we study. And interestingly, the real problem with palliative care is it's thought of just as something a good thing that you might consider doing. And in the field as a whole is very, very new. And the World Health Organization, though, has said that palliative care is an ethical responsibility. And I'm so grateful because I got to go to the United Nations and advocate for palliative care to be included in universal health coverage. And it now is stated, Universal Health Coverage 2030, that palliative care should be a part of that in primary care systems, which is really wonderful. So to break it down to kind of pieces and parts, what we do in palliative care is we help people think about goals of care. We do advanced care planning. We help manage symptoms. We think about psychosocial support and interdisciplinary collaboration. Spiritual support, existential distress, we address these issues. We think about coordinating care, which is, if you imagine, some of our patients and families in our hospital they're cared for by up to 200 clinical providers. 200. Very difficult to navigate, extremely tough to walk through that. End of life care, certainly a big part of what we do, and we make sure that patients have a wonderful day every day. Quality of life, activities of daily living. And one of the things that I've talked to the leaders here about is palliative care is everybody's responsibility. We have to make sure that we're integrating as a system, that we're thinking about this at all levels. And so when you think about it, the on-demand aspect, that's my job. You call and say, Justin, I want you to come see my patient. And I say, yes, let me come and do that. That part's easy. That's the consult service. The second part is something where we partner in advance with patients that might have high-risk disease or significant symptom burden or otherwise, and we become a part of the team. This might be like stem cell transplant, let's say, or high-risk neuro-oncology patients with brain tumors. And then finally is this bottom tier, and that's what we're doing today. That's through education, policies, and resources. We make sure that this institution, yucky word, oozes palliative care. And the cool part is, if you look at the strategic plan, our Koala Pediatric Palliative Care Program supports all 5 of the strategic goals and touches every single area of emphasis. We've had consults already through the Heart Center, the Cancer Center, Mother, Baby, and Surgical Services, and it really is essential and core to the mission of this wonderful place. I'm going to dial in a little bit onto the research and my research and kind of the work that we've done, but I'm going to put this up here too so you can kind of see the way that we think about things. We're thinking about and expanding our clinical operations. We're working administratively, trying to create collaborations across the entire Bay Area. The research I'll come back to in just a second here. We're thinking about educational opportunities. And so when you imagine how do we develop the next generation, we're starting a hospice and palliative medicine fellowship, and we're going to be recruiting for that starting in September. And then actually having our first fellow here in July of 2026, first 2 fellows actually. In the future, we want to also have a fellowship for advanced practice providers, psychologists, social workers, and then also have an academic fellowship where we have an entire year or two dedicated to academic pediatric palliative care. And then we're trying to think through strategic initiatives. And this is one of those that I'm talking with you here today. How do we better integrate into MCHRI, into this really important clinical research we're doing? So that's a little bit about palliative care. I'm going to share with you a couple patient stories in just a minute too. My research, I want to talk a little bit specifically about that. And so one of the areas that I do research in is in patient-reported outcomes. So as an oncologist, interestingly, the most common curve that we look at is called a what? Yeah, so it's, some people call it survival, but it's, the fancy name is the Kaplan-Meier curve, right? And this is like a 1, which is yes, a 2, which is no. I mean, a 0, which is no. And so people, you know, the curve, if you look at that, success is only defined by survival. But we know that life is so much more than that. Our lives are filled by moments like these, where we connect with the mission, where we connect with each other, where we talk about quality of life, where we talk about those things that matter to us most. And so when I think about patient-reported outcomes, it's a little bit embarrassing how far behind we are, because how many people in here work on oncology? 1, 2, okay. So there's something called the CTCAE, right? And we know this. This is how you look at adverse events in the hospital. And in the hospital, when you look at these adverse events, the term nausea. Has anyone been nauseated? So historically, guess how we thought if somebody was nauseated? I would come up to Mary, the oncologist, and say, Mary, do you think this patient is nauseated? That's pretty dumb. Why would I ask Mary if her patient is nauseated? So anyway, patient-reported outcomes is asking the patient if they're nauseated. That's the work I do. I work at integrating palliative care. How do we do that? How do we best make sure that palliative care can be integrated into a variety of settings? I also do grief and bereavement outcomes. The really beautiful part of that, and I'm going to share a quick story with you as I close, the beautiful part of that is grief and bereavement outcomes are completely changed by the care that we provide our patients and families today, including giving them an opportunity to enroll in research trials. One of them that I did a trial looking at autopsy study specimens, and participants in that study, their parents had better bereavement outcomes than those that did not. And it was really about legacy. And so as I begin to close, I want to share with you one story. There's a beautiful story and of one of my patients. You're not supposed to have favorite patients, but this is my favorite patient. And Lizzie's her name. And Lizzie, when we asked her what was most important to her, she said, I know I'm really sick. I want to make sure that my family remembers everything about me. And I want to record a song for them. I want to sing a song. And this is the song that she sang for her mama.
I found a love for me. Darling, just dive right in and follow my lead. Well, I found a girl, beautiful and sweet. I never knew you were the someone waiting for me. We were just kids when
I know it's very light, but I also know you can make it out. And her beautiful voice just resonates with me. And I see her huge smile as she's singing this song. This work we do is so important. Every day, the work that you do, and as you support people like Lizzie, as you help her be able to enroll in these clinical trials, to give back to her mom in the way that she did, in this way that helped her legacy live on and on. Imagine the regret she would have if she didn't have that recording. I'm so grateful to be here. I'm so grateful to be meeting with you all. I'm so grateful to our leadership team for supporting our quality of life and pediatric palliative care program. I have brochures up here. I have extra koalas. I know some of you feel really badly about not catching one. And so at the end, I'll hang around and answer any other questions. But I just mostly want to share with you the work you do is essential for our precious patients like Lizzie. Thank you.
Justin, thank you so much, and particularly for sharing Lizzie's story with us. Very, very touching. I got to move on because I'm quick to tear, and otherwise I'm going to tear up with Lizzie's story. So just one comment. Yes, Justin will be available for discussion, questions, comments, whatever at the end. We kind of thought we would push that all to the end so we can keep moving through the program. I noticed that the R in CARES, which is your research component, is right in the center of your acronym, and it seems like it's informed from both ends. So again, I think Justin really is emblematic of the type of message that we're trying to send today. So thank you again for your comments. Appreciate that. Okay, next up is Tom Caruso. Tom is the clinical professor, anesthesiology, perioperative, and pain medicine. He also directs the CHARIOT. Sorry, that's the end of yours, and that's the in between. Sorry, he directs the Stanford CHARIOT program. He has a special interest in regional anesthesia, quality and safety, medical education, and immersive technologies used for childhood pain and anxiety reduction. I have to say, I've known Tom for years. We see each other in the operating room. We care for patients together, and I had no idea what CHARIOT was until about a year ago. And then we got to know CHARIOT. We got to know Tom. Absolutely, again, what a fantastic program. It super meets the mark as far as being a translational and super innovative program. Tom's going to give a few introductory remarks about that, and then we're going to bring up our absolutely special guests of a family who's going to speak to their perspective on this. Tom, come on up.
Thank you, Carl. Thank you, everybody, for coming today, and thank you for the invitation to be here today. It's really been quite a journey for the Stanford CHARIOT program, and I'm very appreciative of everyone in this room and the support we've had throughout the years. A little bit about us. At the Stanford CHARIOT program, I'm just going to read this because we spent a lot of time on this. Our innovative immersive technologies ease patients' pain and stress, encourage rehabilitation, and enhance education to restore a child's sense of normalcy at Stanford Medicine, Children's Health, and at other hospitals around the world. That may sound like a bold statement, and we're not going to get into this today, but actually everything you're going to hear about, we at Stanford University license at no cost to hospitals around the world. We're in over 50 domestic hospitals in over 40 countries, targeting mostly limited and resource variable areas. So importantly to remember, the clinical and translational research that you've heard from today does not just impact the patients that we care here for every day, but has the ability to impact patients everywhere. And as we heard Dr. Baker's talk at the WHO and helping palliative care come to everybody everywhere. So like Dr. Sylvester mentioned at the top of the hour, he said, clinical translational research starts with the patient, ends with the patient. So this is the patient we start with. If anyone has any children in this room, or know a child, or perhaps was once even a child themselves, you are very familiar with this scene. This is a scene of the child absolutely losing their mind. It could be over taking a shower at bedtime. It could be over having to have a surgery. Anyone wants to know what happened to this child right here? Don't worry, no children were harmed in the photographing of this slide deck. This is actually my daughter, and she was brought in on a Saturday to take photos for slide decks for our presentations. Everything seemed cool, good to go. My colleagues who run the program brought their children. They're hanging around. They seem cool. Okay, Charlotte, here we go. Hold the mask. We're going to take your picture. And then this. Okay. Yeah, I guess we're not doing this today. So you can only imagine what happens to the children that we take care of in the operating room, on the floor. Dr. Baker takes care of in oncology. These children are in very unfamiliar environments surrounded by very compassionate people who want to make them better, but nevertheless unfamiliar people. And this unfamiliarity can sometimes be difficult for children to process. What we try to do in the Stanford CHARIOT program is, like we mentioned, take that child's experience and bring it back to some sense of normalcy. We're a very unique program. And you may have heard the term bench to bedside or translational research. We've talked a lot about that today. What we do is we see a problem and we start in a technology lab. We develop our own software. There's a lot of off-the-shelf software out there, but rarely is this perfect for our patient and the patient care we want to deliver. After we develop software, occasionally we find that we need complementary hardware devices to help. It was very funny. I'm probably not allowed to say what company. I was giving a talk to a company the other day and they said, who built this, this vibrating penguin device we call the Bodyguard? And I said, we built it. They're like, yeah, I know, but no, like we built it here at Stanford from scratch. We do hardware. We're like hardware engineers. We do software. We're software engineers. And then we take our discoveries and we study them with our patients in real time. We take the learnings from our research and then we apply them to developing clinical protocols. And what makes the Stanford CHARIOT program special is that we're not just a research lab. We actually have a clinical teacher on our program. I saw Faith Collins over there. We call her Dr. Collins because she likes to be like Dr. Gray. She's working with the Stanford in-hospital school. We've got Laura Wasserman right here, one of our child life specialists that works for the CHARIOT program. We have Mary Hunter, one of our physical therapists. And these clinicians work with patients every single day to bring our research and technologies to clinical care. We work mostly in three main pillars: anxiety reduction, education, and rehabilitation. And by the numbers, this is 870 participants recruited in just this past year. We enroll a lot of patients clinically at this hospital. We run a summer program where students who are looking to help children, some of them are looking to go into healthcare. We have a fellowship over the summer that's very popular, draws people from all over the country. We collaborate widely with everyone at the Children's Hospital and in the School of Medicine. We have many headsets and other technologies in the hospital, and we publish quite a bit. And that's what we do. The coolest thing that we did most recently is we started a consult service. And for those of you who don't know what that means, perhaps you have a patient and you can put in a consult for a cardiologist or an oncologist or palliative care to come see your child. You can actually put in a consult now through our electronic medical record to have someone from our CHARIOT care team come see if we can use technologies to improve your patient care.
I do have to say a few thank yous of our own on behalf of Maternal Child Health Research Institute. Of course, our two speakers from leadership, Rick Majzun and Mary Leonard. As always, thank you for your support in pushing these things forward. On our team more closely, Mary Chen, who's the executive director of MCHRI. She's my partner in all things CRSO, along with Allison Falwell, who you heard earlier. Kevin Morrison, who's been on point to put this whole program together, along with the help of Netta Miller from MCHRI Marketing, and Harmon Gill from MCHRI Administration. And so I wanted to make sure I shout out to Netta, Harmon, Allison, Mary, and Kevin. Big thanks for all that. That's our program for today. The speakers are here. You're welcome to mingle, get food. We're going to still be here for a good half hour, 45 minutes to an hour. Come and meet folks, chat, strike up a conversation, and see where you fit into this puzzle, because you're all welcome. And thank you so much for coming today.